Okay, this is the soap note for Mr. CC. He's a 75-year-old male with a chief complaint of chest pain. Per patient, the pain comes and goes once or twice a week, sometimes every other day. Pain is located on the left side of his chest, and yesterday was more so sternal, so it doesn't stay in the same place. Patient states the pain comes and goes to a max of 2 out of 10 and lasts for 20 minutes. The pain presents without any activity or exertion. Nothing makes the pain worse or better, and patient denies any other symptoms or radiation of pain. No change in ADLs. The patient is able to go about and do things for himself, which is nice. Past medical history. He does have a past medical history of MI, diverticulosis, vitamin D deficiency, dementia, coronary artery disease, GERD, dyslipidemia, depressive disorder, morbid obesity, hypertension, and calcineal spur. He has allergies to amoxicillin. Before, he used to live alone in his apartment. He was a recent admission not too long ago. He's not married. Review of systems. I don't know why I keep saying symptoms. Sorry. Review of systems. Denies chills or loss of appetite. Respiratory, denies shortness of breath. Denies difficulty breathing or pain with inhalation or exhalation. He endorses chest pain, 2 out of 10. Denies radiating pain, and the pain comes and goes. GI, denies any abdominal pain, nausea, vomiting, or diarrhea. Neurological, denies any headaches, numbness, or tingling. Psychiatric, his affect was normal, and no changes in mood or behavior. During the physical exam, we took his vitals, blood pressure 103/58, 68 heart rate, 18 respirations, 98.6 temp, and 96% on room air. So, general, obese, elderly male, not showing signs of acute distress upon entering patient's room, patient resting in bed, no dyspnea observed, Respiratory, clear to auscultation, bilateral lung sounds, no rales, bronchi, wheezing, or cough. CV, heart sounds, S1, S2 present, apical pulse within normal limits. We did find +3 pitting edema to bilateral lower extremities, and no murmurs were heard. GI, he's obese, but no abdominal distension. Abdominal was soft and round. Endorses chest pain upon palpitation to the left lower quadrant. We were thinking that had more to do with the diverticulosis. When I was pressing that area, just from what I've seen in my background in the ER, that's what I asked him, and he did confirm. Bowel sounds were present. Neurological, baseline neuro, AO times 3, no changes in upper or lower strength. Baseline, psychiatric baseline per patient, normal affect, he was calm, pleasant. Medications, he's on quite a bunch, Tylenol, Modipine, he gets zinc, for his nose, for his folds, vitamin D, and other medications, For assessment and planning, so chest pain, likely non-cardiac due to the various places he has it. This was discussed with my NP. Possible worsening of CHF due to the bilateral lower extremity edema. So discussed if he could be maybe spilling, which could be just causing the discomfort in his chest. The EKG was ordered and obtained. We didn't find any acute findings, and we did refer it back to other EKGs to compare to what he's had before. There was he was basically at his baseline. So I saw the note that you put in for his blood work. So we did order CBC, CMP, and BNP. The BNP was to see if we would need to basically have to order Lasix because he doesn't have any Lasix as far as like standing order in case he goes into CHF exacerbation. And so she said we'll review. As far as troponins, they weren't ordered because of the fact that he it's not something they can follow up with. Ideally, from what I've seen, troponins are usually ordered, at least when I've worked in the ER. We would order them, and then we would reorder them within a 3-hour time period or an hour, depending on where you work. It all depends on the facility. Usually it's between 1 to 3 hours for anyone that has chest pain. And that's how we'd look and see if they're possibly NSTEMI and so forth. But in this case, they don't have the means to do that. They don't have the means to get those ordered and then reorder and so forth and do that kind of follow-up. She said if it felt the necessary need for her to have done that, he would have been sent to the ER if it was that concerning. I believe, like, as far as the lipids, I can't remember if those were already in the CMP. I can't remember. And the A1C, I don't believe he has a history of diabetes, and that's the reason why. She said that she didn't need to because he did have blood work ordered from before, so it wasn't a concern for her to order the A1C. So we did discuss that. And the other thing I think I wanted to discuss was that we did talk about. I think it was mainly the extra fluid that he had, and that's what kind of bumped the question, or asked the question as far as ordering the BNP to see if he's in CHF overload. So that's the patient for the previous week of 120, I believe. So yeah, thank you.